So we're now live and we're just recording has started. Vic, over to you.
Thank you. Hello, everybody, and absolutely delighted to be joining you today at this Learning Summit. So my name is Vic Rayner. I am the Chief Exec of the National Care Forum, and I'm also this year the Chair of the Care Provider Alliance. So it's a great pleasure for me to have an opportunity to look at this first learning network of the year, which we're looking at the integrated workforce planning in health and social care. It's a hugely important topic and one that we know has garnered a lot of interest from many of you who've sent in some fantastic ideas and thoughts and focus for us, which we hope to pick up on and cover during this session. Workforce is an enormously important area. When I talk to members and talk to organisations across the sector, it is one of the driving pressures, but also a sense of and source of pride for organisations about the fantastic work that their colleagues deliver each and every day from across the sector. We know we're in the situation now where we have a new government and a renewed focus and commitment towards workforce. A lot of that focusing at the moment around issues associated with pay terms and conditions, with the discussions around fair pay agreements. But we also know from our colleagues in Skills for Care, who produce huge amounts of data about the social care workforce, that we continue to be in a situation where there are high levels of vacancies and levels of change within organisations that we want to address around recruitment and retention. It's been really interesting over the last few years to think about how much that workforce has been asked to deliver against a broader range of integrated tasks and activities integrating with our health colleagues. So it's very timely that we are thinking about how do we make that more strategic? How do we encourage that engagement across systems so that we can have some proper integration in our workforce for the future, so that we can meet head on across communities the challenges and opportunities that the delivery of health and care presents. So I'm really excited to have the opportunity to hear from our expert speakers and to join you again in discussions around the panel a little bit later on. But for now, I'm delighted to hand over to my co-chair, Rebecca, from NHS England, who will have an opportunity to tell you a little bit more about their involvement in this fantastic learning network. So over to you, Rebecca.
And just to clarify, I'm from NHS Employers, which is part of the NHS Confederation.
I beg your pardon.
And delighted to be here joining this session today. I've been particularly engaged in some work over the last sort of 2 years with Skills for Care and Partners in Health, and we've developed some guidance and support around integrated workforce thinking, and it's been a really enjoyable part of my career working with other colleagues in different sectors and understanding their worlds and the importance of language, I think, and how we use language we say the same words, but they mean very different things. And that's been one of my key learnings, I think, from that work. I think there's some really positive signs, as Vic said, around the new government. The 3 shifts that they've talked about around moving from analog to digital, from treatment to prevention, but also about the focus on community and neighbourhoods, I think is really creating opportunities that hopefully we've spoken about for a long time, but hopefully we will see some changes as a result of that. So as Vic says, we've got some really good presentations to hear from today. So I'm delighted to be able to introduce colleagues to talk about the workforce care pathway early adopters and to share their lessons that they've learned. So I'm going to hand over at this stage to Deborah and Joshua to introduce their session. Thank you.
Okay, good morning. My name is Debbie McNally and I'm a Leadership Development Coordinator and Locality Manager from the Brandon Trust. And together with my work colleague Josh Vickers, who is a project manager at Brandon, we've been leading on being an early adopter for the Care Workforce Pathway. Today, we'd like to share with you what we have learnt and how this has benefited us. So Brandon is celebrating our 30th year this year of working with people with learning disabilities and autism to live the life that they choose. And we were amongst the first to support those individuals to build new lives away from institutions. We cover a large area across the south of England, supporting over 1,600 people with a workforce in excess of 2,000. So Brandon has been and still is committed to being at the forefront of social care reform and recognises the importance in attracting and retaining the right people with the right skills, knowledge and values, and the undeniable link in the level of experience the people being supported receive. So being an early adopter and testing out the Care Workforce Pathway aligned well with our own values and beliefs in what is needed to ensure positive change happens to attract and keep and strengthen the care workforce. So we've been working with a number of providers on the first cohort in becoming an early adopter, and we were invited to test those proposals with our colleagues in Cornwall. And we're here today to share with you how that went. So the pathway, as I said, strongly aligned with our values and beliefs, and also strongly aligned with Plan B, which are our strategic objectives. So whatever our pathway becomes, it will positively impact on all of these. It will ensure that we do have the right people with the right skills and values, but also that they have clarity around their roles and responsibilities, and also understand how they can progress to a variety of roles or develop within the one that they enjoy. This could involve a qualification, training, coaching or mentoring, thus ensuring we are a well-led organisation.
So our progress so far. We have completed 2 mapping exercises. One of these was for values, in which we found that our values align closely to those of the Care Workforce Pathway, with only small language differences. And a job mapping exercise, which compared our job descriptions and specifications against those of the pathway. Here we found more significant differences in both content and language. We have also completed our first testing cohort, which we'll explain later in the presentation.
The roles A and B were fairly straightforward, with new to care and those who have more experience linked to qualifications. Roles C and D were more complicated due to 3 main factors. So we don't have a widespread role currently of senior or enhanced support worker, nor do we have many specialist roles outside of expert practitioner teams, such as positive behavioural support. Also, our line management roles, including the first role of team leader, encompasses the full responsibilities of the people they lead, and those responsibilities cross over roles C and D. Brandon has a manager's induction process and a leadership programme in support of that development.
In cohort 1, we tested roles A to D in Cornwall. We delivered an awareness session to those taking part in testing to support managers to understand the documentation and the process we would follow. The participants then completed their self-assessments prior to a meeting with their line manager. In this meeting, they participated in a career conversation for which a guide was available to support the line manager. The conversations culminated in the completion of a development plan for the participant, which set out their aspirations and areas of development. We conducted pulse surveys, prior and post testing to see the impact of the testing on both the line manager and the participant. The gathering of data from cohort 1 has given us insights into our workforce's career aspirations. A large portion of our support workers want to progress into a specialised job rather than going into management. Only 28% of our support workers expressed an interest in becoming a team leader. Most support workers wanted to stay as support workers, and our team leader group was split almost evenly between wanting to stay as a team leader and making the next step to locality manager. Team leaders in our organisation hold responsibilities that could cover both roles C and D. We therefore decided to split our team leader group testing between both pathway roles to understand which role our team leader position aligned more closely to. We can see from testing that our team leaders aligned closer to role C than the role D, which has a more complex set of skills associated with it. We also found that questions relating to technology and digital scored lower than the other categories, and health and safety scores also reflected this. There are some gaps in quality and compliance-based knowledge within our workforce, including knowledge around legislations and the duty of candour. Cohort 1 also allowed us to test and evaluate the testing process. From this, we identified some areas of improvement. The skills assessments would need to be digitalised if we want to use the data from them. The skills assessment would also benefit from having the questions categorised. The digital skills element needs to be simplified and slimmed down to make it more relevant for our workforce. The link between the skills assessment and development plan needs to be explained further to the teams, and the skills assessments may also need to be tailored more to the supported living care that we provide. Managers may also require some extra training on how to conduct the career conversation to ensure the conversation is effective.
We're currently testing the remaining 2 roles, E and F in Cornwall, to provide us an insight into all 6 operational roles. We will streamline and digitalise the process, which will require focus groups to ensure we ask the right questions to provide the information we need to decide how best to integrate the care workforce pathway. A key consideration is how to bring the pathway and existing and future work together rather than existing in silo.
Utilising the data from the skills assessments and other pathway documentation is vital to give us the insights we need. To avoid the manual entering of this data as we did in cohort 1, we intend to integrate the documentation into our digital platforms to enable us to streamline the process and make it easier for our people. This would not be possible for the DHSC testing due to data protection concerns between organisations. Internally, however, this would not be an issue.
Those specialisms were mentioned throughout the job mapping process, often described as ways to progress. However, in supported living, we are driven by the needs of the individual. So in many homes, there are often multiple people being supported with a variety of needs. In reality, this means that staff become specialised in many areas at once, and this becomes business as usual. Yet pay and reward don't necessarily follow. A further example is how many healthcare tasks, such as diabetes blood sugar monitoring, INR levels, and much more, previously performed by nurses or other medical professionals, are now performed by support workers, again with no change in recognition or reward. Sourcing the right training and an acknowledgement of the shift in tasks needs to be recognised and addressed. So it's fair to say it's not been plain sailing pre and post election to always get clarity around qualifications and funding, but it is getting there. We're committed to continuing our offer of targeted qualifications and training and understand the role they play in attraction and retention. Care Certificate 2 will enable us to expand the audience and enable people to access a qualification earlier. We await further information and clarity around what it might look like post-April 2025 concerning the full offer available, including training around more specialist aspects of roles and what that means for funding. During this time, our testing will continue. We are also working with the Department of Health and Social Care, looking at qualifications and training in our sector and what is needed to ensure that the workforce has access to the right qualifications and training to evidence their competency and, importantly, provide opportunities to progress for those that wish to. Summary, the pathway has been extremely valuable for us in reassuring us in areas we felt confident in and allowing us to explore how to further improve other areas, to challenge where needed as well, perhaps where we might have held a different point of view. We will now be rolling out further testing across the organisation to collaborate with our staff to ensure that we provide our current and future workforce with what they need to reach their potential, feeling valued and supported, and ultimately stay in social care. Thank you for your time this morning.
Thank you so much for that presentation. We do have some time for any questions that people want to post, and they can do that by putting them in the Q&A section of this webinar. I think, Victoria, you were keeping an eye on those. Is there any that have been posted for our speakers from Brandon?
Yet. No, so we might just take our second item, please, Rebecca.
Okay. There was so much in there, and I'm sure people may need to just reflect on that, and there will be an opportunity to ask questions at the end as well.
Rebecca, sorry, I wonder, it's Vic here. I just wondered if I might just ask a question. I should have put my hand up. Apologies. But just a question really for Debbie and Josh, which seemed to be about this sort of crossover between roles. I was really struck by you sort of saying actually people were doing, you know, C and D and possibly some B. And I just wondered if there was a reflection on the size of teams and that you were testing it with, and whether there was anything that might come through from that. Because I know that your work often is in quite small cohorts of people that you're supporting in different settings, and I wondered if there was any reflection on that as well as all these other hugely rich information that you were sharing.
I think we tested in Cornwall to keep it geographically to be able to do the testing, but the organisation as a whole, the roles reflect across the organisation. So I think particularly with our leadership roles, we do have an expectation that when somebody goes into their very first leadership role or changes within the leadership network, that they are leading and managing from day one in the fullest context. But we are fortunate in having a leadership development programme, which I run with a job share, right from induction through many leadership skills, because it is a sizable task. But we would find it really difficult, I think, to split out certain leadership and managerial tasks. So in some of the job mapping, it would say you're leading and managing, or you're not doing that till role D, or you're leading and managing, but somebody else would do the one-to-ones. Whereas we would find that really hard to strip that out, because once we believe anyway, once you're leading and managing a team, you're leading and managing a team in its fullest format. But we need to do that. And I think the other thing that stands out is the level of specialisms. And we were fortunate to have 3 ladies from the Department of Health come out to Oxfordshire, and they went around 4 or 5 homes with me, and I think they were struck with a level of expertise in supported living, because in one home we might have 3 or 4 people with many needs that would fit into all sorts of specialisms, and basically our support workers get skilled to do it, and they carry on and do it without being recognised as having a specialism, and that is including more and more delegated healthcare tasks.
Thank you.
For that. I also wondered if I could just ask one more question, and that's, would you recommend that other care providers look at the care workforce pathway, and what opportunities and benefits they may learn from the early adopters?
You want to take that, Josh?
Absolutely. Yes, I think we'd strongly recommend that providers interact and become a part of the journey the pathway's on. Throughout the process that we've been involved in, the DHSC have been very open to suggestion. They're learning along the way. They're listening to the voice of providers across social care, and we are also learning from each other. So in terms of, is it more work? Yes, of course. But that work is so valuable in learning from not only each other, but also informing what the care workforce pathway will look like in the future. So if we want to contribute and make this something that will really make a difference to social care and the sector, then I suggest that as many providers be involved as possible.
Yes, I agree.
So that's been great. Thank you so much. So I'm now going to move us on to the next learning session, which is from Kate Simpson, who's going to share the work that they've been doing in Leeds, looking at how to make home carers roles more rewarding. So I'll hand over to Kate now. Thank you.
Hi everyone, thanks so much for inviting me today. So today I'm going to talk about our new model for home care, which is the Leeds Community Health and Wellbeing Service. It is a brand new pilot started in September. So just to caveat, everything I'm saying is this is very new. So why are we introducing a new model for home care in Leeds? Well, one of the biggest drivers was around market management, in terms of our original framework contract failed, and we've ended up with a lot of spot providers. So we've got around 150 providers in the city, and there's very little opportunity to create meaningful relationships and for our market to grow and be sustainable. We also really wanted to improve staff recruitment and retention within our care workforce. When we started the project, it was as high as 40% turnover. Leeds has got a big and growing economy, and we're always competing with retail and leisure. We really wanted to promote the partnership working, like I said, with so many providers in the city. It is really hard for social workers and healthcare teams to build meaningful relationships with our home care providers. And we thought that was such a missed opportunity because we're all working towards the same goal of supporting people. We do want better services as well. We want improved consistency and quality across the board. We can't contract manage meaningfully and develop services in partnership with our market with so many providers. So we wanted sort of quality and personalisation to be the key drivers for change. Also, by having fewer providers working in a locality, you are going to benefit from efficient runs and rotas. So how we got where we are. So we did a very small scale pilot started February 2020 with 2 providers, just to test that locality model and the difference it makes having single providers working in an area. It was reviewed by Leeds Beckett University and immediately saw benefits for service users, people who draw on care and support, particularly the staff. One care worker said the new model felt like the shackles had been lifted because they were allowed to personalise the support they were delivering rather than just sticking to a list of time and task. We did an awful lot of data analysis to come up with a new model and its affordability. We got a deep understanding of our service, looking at the different social work teams, how they operate, looking at finances, both internally and from providers. We did do a deep dive into electronic call monitoring, looking at the amount of hours that we commission as a council, that providers plan for, and that are delivered in people's homes. And we did a lot of looking at sort of the demand analysis in terms of making sure that the model is sustainable and affordable. We did tons of consultation. We're really proud of our citizens panel who put a lot of work into this. They met over 8 sessions supported by Health Watch Leeds, and they actually gave us 26 recommendations at the end of it. All of which we put into our service specification. We've continued with an active citizens panel who supported us in the journey to roll out and delivery. We had a really good provider consultation as well with a panel of large and small providers inputting their views into how home care should change in the city. We really worked closely with the social work teams, particularly the ones who were affected by the pilot, and finance officers. All of this to say is that we can't deliver a new model just by looking at the provider side of things. Every part of this jigsaw had to change to deliver the new model that we're looking for. So what is the new model? So we're looking at 4 key areas of change from that consultation. The first one was around payment of care workers, and paying for whole shifts was a real priority for the workforce and the market, and also, you know, leased to councils as signatories to the ethical care charters. We wanted to improve social and community connections. From the data, we knew that we are over-commissioning hours in many areas, so we want to find ways of right-sizing packages of care and hours to better meet the needs of the individual. And also, the holy grail is commissioning on outcomes, and we've introduced a new outcomes monitoring form. Very simple, but it is aimed to design care around the person's goals and outcomes, and that's a really important for us. And also around promoting independence as well. So those outcomes are around somebody's independence goals, and, you know, doing with, not for, and maintaining their independence, and working in a re-abling way. So we had an open tender. We were only piloting in 3 wards in the city, around 200 people, and 2,000 hours. So like I said, we started in September. So we've now got 2 providers working in these 3 wards. We did have 27, and we aim to move as many people into the new service so that our providers could start with a decent chunk of hours. The model is small neighbourhood teams, and the interesting thing is it's co-commissioned with our local Leeds Community Healthcare Trust, and so the new providers are taking referrals from both adult social care for home care, but also Leeds Community Healthcare. So we're starting off with sort of tasks and visits that are aligned with the care workers' roles and responsibilities and skill set. So it is medication prompts, catheter care, stockings, activities of daily living, you know, supporting their rehabilitation work. We would like to work towards the clinical delegations and the true delegated healthcare, with insulin and wound care, 2 areas we want to explore. We've been lucky enough to get some funding from the RAIN Foundation for a clinical manager to help us work towards the clinical delegations with the correct governance, and we're keenly following national work around this as well. We want to build stronger local relationships, and have coordinated care around the person. Everybody walking through their door should know who everyone is and what everyone does to support that person, so they are at the centre of everything we do. Providers now have a key role in care planning. So instead of the social worker doing the assessment and presenting the provider with a list of tasks and times, the providers are now in a three-way meeting with the individual, their family, social work, and they design that care plan together. So you know, it's really paying dividends, those meetings, to coordinate care, set expectations, and develop the relationships and trust. We are already seeing the benefits of that closer working, you know, particularly with the providers and our social work teams. We have fortnightly case management meetings. So instead of just emailing duty and waiting for a social worker to be assigned, you know, we can have live conversations between providers and social workers to sort out any issues. Nursing teams are already saying how fantastic it is to know who the care provider is and to be able to communicate with them directly. And that's only going to grow as soon as our visits delegated from Leeds Community Healthcare start next week, we hope. Opportunities, you know, plugging into our fantastic third sector that we have in these wards. They've started a little WhatsApp group between the third sector, social workers, providers, care homes, and they're all telling each other what's going on, you know, who's starting a new session, who's got a coffee morning on, and just, you know, sort of sharing those social opportunities so that everybody knows what's going on in the area. Oh, sorry, just to go back to the big one is the new deal for care staff, which is we're working towards paying staff for their full shift while they're at work, and we have invested in a higher hourly rate to cover some of the gaps in the rotas, so that care workers can be paid for the full time they're at work. We're hoping that the Leeds Community Healthcare referrals will plug some of those quieter times as well once they start. Again, like I said before, you know, that quote about the shackles coming off really made us appreciate the care workers' role and the special relationships they have with the people they support. So it is giving them the flexibility in terms of how they deliver the support. Also, there is some flexibility in times, you know, so long as the person's getting their hours over the 4 weeks, there is a level of flexibility, but also that is a challenge because people want the visits at the same time. So we're hoping that if there are gaps in rotas, they can bob back and see somebody, or, you know, make an appointment for the GP, etc. Just go above and beyond when they can. This is a new service, and we've got shared training for all of the care workers to deliver this new model. So yes, it's not without its challenges. I think it's important to be honest with everybody. Affordability is going to be our biggest challenge, not just for providers paying on the shift. We've got 2 months data now, and there are still gaps in the rotas that they're struggling to afford. So we're currently paying in blocks of hours, but there are sort of 2 or 3 gaps in the rotas, which sort of splitting the shifts up. So we want to move towards you know, full shift payments once hours increase. I mean, we did look at 9 different payment models. So for Leeds City Council, the investment in the hourly rate needs to be offset by reducing the overall hours that we're paying for, and that's through, you know, reablement, not increasing packages, you know, avoiding hospital avoidance, but also you know, us commissioning the right number of hours. Like we looked at 9 different payment models, and it was really hard because hours is the currency, both for the providers in how they organise their care and you know, cost their services, but also for the individuals who are billed for the hours that are delivered. So that is a huge challenge. Culture change, always going to be a challenge. Whilst everybody, you know, is really up for this new way of working, it is a massive change, and it's not just, you know, so providers delivering a new model, it's all of us delivering a new model, from social workers, healthcare professionals, commissioners, ourselves as well, moving away from this transactional service that's existed in the past. We really want to work towards senior care worker role, and we're committed to, paying for additional training that care workers get on delegated healthcare. It is going to be a challenge, and it's something that we're working towards through the RAIN Foundation funding. So this is a watch this space, but we do want to make sure that that staff who take on additional responsibilities are paid for that. No getting away from that. This new model will create a lot of market disruption. Like I said, we went from 27 providers to 2 under the contract, but 20% of people opted to stay with their existing provider on a direct payment. It has been, we have successfully transferred people over, people who were, resistant to change. So it's important to get those early conversations going with individuals who might be affected. One thing we really would need to work on if we go citywide with this new model is supporting small providers. Most in our city had never submitted a tender before, and I think they didn't really, we didn't really prepare them for the tender process and what you need to write in a tender, and what what good bids look like. So we're doing a lot of training, but also how do we model our new contracts to level the playing field between the big providers, who are very experienced at writing bids, and the small providers who are not so experienced at writing bids. So it's a real challenge, but an opportunity, I think, working with our procurement colleagues to make sure that small and large providers can benefit from the new model in the future. That's it from me. Thank you very much. Yeah.
Thank you. That was really informative, Kate. And I think you've acknowledged that it's early days, and you're still, testing things and finding things as you going into this process. There are a few questions, so I will just scan those, and I think one of the ones that I thought of, and someone else has also put in. Can you say a little bit more about the monitoring outcomes? How are you doing that? Exactly what you're monitoring? Can you just say a little bit more? I know you said it's quite simple, which is also probably a good thing.
Yeah, so the outcomes monitoring, we created a form, but our providers have been able to put it into their own digital platforms, and basically it's sort of my independence in my home, community connections, and oh God, what's the last one? I can pop. Yeah, I can't. Sorry, my mind's gone blank because it's a while since I looked at it. But so what is that? The person they scored themselves on, the areas that like I want to be able to, continue to make my own dinner, and it is about how that support is delivered and adapted to support them, and that would be like learning their recipes and taking the time to help people remain independent. If it is, I want to get out and about in the community, then it would be around, looking at what's out there. And we're allowing, we've got community hours, which are additional to somebody's care package and not chargeable to them, where the care workers can support them to attend a luncheon club, potentially to, reduce a lunch visit, to get out and about where confidence is an issue. So so every 6 months they look at the scores and they look at the goals and they're meeting the outcomes that they wanted. So yeah, it's kind of standard outcomes monitoring, but again, commissioning for those outcomes is, it's something we would love to work towards.
Good. There's been some questions about, will the slides be shared? And yes, the slides will be shared. And I don't know whether Kate, that's something into the outcomes framework, whether you could share that.
I will, yeah.
And then they can be shared with colleagues on this session as well.
The providers really like using it, and it's there at this 3-way meeting where everybody kind of agrees the plan, but also checked at 6 weeks and then regularly monitored.
Also, some questions, if you could say, I think you have covered it, but maybe just revisit the how were the enhanced hourly rates funded?
Yeah, so it's so this is the investment that the council's making. It's coming out of our home care budget. So we pay a higher hourly rate, but the individual is only billed at our standard rate. So so it's not a negative impact on the individual, but yeah, so what we've done is we have invested in it, and then our director has said it has to wash its face. We're having it independently monitored, because actually seeing how such a dynamic and changing service with lots of different people coming in and out of the service, it's hard to see, yes, it's costing us exactly the same as it would if it were on the standard urban rate. So we're looking at a lot of areas in terms of affordability, around hospital avoidance. But again, it is around right sizing those packages and inputting those reductions. And actually, we found when people moved from one to the other, hours were reduced, and obviously that reduction in hours is offset by always getting the new people coming into the service. Does that answer the question?
I think hopefully colleagues can follow up if they think there's anything more. There was another one, which was, does this include short-term provision in terms of intermediate care as well as long-term packages?
No, not at the moment. Into our sort of intermediate care reablement service is delivered in house. So no, not at the moment. It's the home care services once somebody's finished reablement or has just as a care assessment and eligible care needs.
I just wondered how any sort of feedback from the staff, if we just finish off with that one, and patients, if you've had any sort of early feedback.
Yes, so so staff, they do love it, because the runs are so much shorter. So staff who've moved from one provider to another are saying the difference that it's making, but also staff who've moved from one part of the city into this one, they do really enjoy it. Interestingly, a few of them feel a bit weird about having the gaps in the road and being paid, whereas before they might have had 15 minutes where they were sat in the car. They're now like, oh, how do I fill my time? So we're giving them lots of ideas, but also, one of the important things is for their own well-being. It's a challenging job, and just taking the time, sort of to reset and have a breather. That's also fine too if you haven't got something to do or someone to bob back. But things like looking up somebody's favorite recipes, all of these things can be done, and it's just giving the care workers the sort of motivation and inspiration to use that time effectively.
That's been really fabulous session. Thank you, Kate. I'm now going to hand over to Vic for the next session, which is our panel discussion. Thank you.
Thanks so much, Rebecca, and huge thanks to Kate and Debbie and Josh, who have given us just such an amazing start to this discussion, which I suspect could run on for many hours. Fascinating stuff. So I am going to introduce our fabulous panel. We've got three great speakers here who are just going to give us a couple of minutes just to start us off with their thoughts on both a little bit of reflection on integrated health and care workforce in action that we've already heard from colleagues, but understanding what they think are the key enablers in moving forward this integrated health and care workforce agenda, and any kind of reflections that they have on the national context and policy levers which sort of system leaders should be aware of. So that's the sort of framing that I'm going to give them a couple of minutes each just to say a few words about that, and then we're going to move into questions from the audience. So please do start putting things into the chat around the panel discussion as well as the other questions you've got there. And we also, as Rebecca mentioned at the beginning, we asked you a little bit of a sense of what you wanted from this discussion, so we can also weave some of that into the discussion. So I'm going to introduce each panelist one by one. After I've introduced them, I'll give them a chance to do their couple of minutes and then move on to the next one and introduce that panelist. So if I start off with Jane. So I'm absolutely delighted that we have Jane Brightman with us, who's the Director of Workforce Strategy for Skills for Care. She's been leading on the implementation of the Adult Social Care Workforce Strategy for England, and I'm sure she'll talk a little bit about that. She has got over 30 years of experience across the adult social care sector, including frontline care, leadership, education, digital transformation and national policy. She facilitates an online network of leaders in social care with over 8,000 members. It keeps on growing, Jane, which is brilliant. And in 2022, she was awarded an honorary doctorate from Arden University for services to social care. So, Jane, I wonder if you could just give us a couple of minutes of your thoughts, and then we'll bring the other panel members in. Thanks.
Lovely. Thank you, Vic. That's such a lovely intro. Makes me feel quite old, 30 years in adult social care, but it's a wonderful place to be. Yeah, hi everybody. So as Vic said, I'm Director of Workforce Strategy at Skills for Care, and we have led across the sector with colleagues across the sector on the development of the Adult Social Care Workforce Strategy for England, which we launched in July of this year. Feels like a lifetime ago, only a few months ago. And it was a really great example of health and social care coming together in a very integrated way to think about the workforce needs across the sector and across health as well, so across the whole system. And we worked with some amazing colleagues across the system, including Leeds, who we worked with really closely on the case study that you've just heard about. We did include a case study on the Leeds model, and we've just recently done a blog post with colleagues from Leeds too, because it's such a great example of that kind of shared working across health and social care. And we got lots of other examples of that peppered throughout the workforce strategy. And for me, I think the key there is leadership, leadership across health, social care, integrated care systems, local authorities. That's where we see the magic happen in terms of integrated care systems and integration across both sectors. So the workforce strategy, as I said, is sort of the first of its kind, really, for the sector, very much led by the sector for the sector. It's a 15-year strategy, but one of the key recommendations in there is that integrated care systems develop one workforce strategies, so looking right across the system at both health and social care workforce needs and coming together. And when we started to develop the workforce strategy, we worked really closely with NHS England colleagues and colleagues across NHS employers to really ensure that we could stitch the two strategies together once it was developed. And so now we're starting to work on how we do that, looking at a review process for next year when NHS England are exploring reviewing the NHS long-term workforce plan. So lots of exciting things going on in that space, and I'm sure we'll talk about them later, but I'll hand back to you now, Vic.
Great. Thank you, Jane. That's fantastic. So I'm going to invite Carolyn Nice in now, if that's possible. Thank you. And Carolyn, lovely to see you. Carolyn is the Director of Adults Health and Wellbeing at Stockton-on-Tees Borough Council, and she's also the workforce lead for the Association of Directors of Adult Social Services. Carolyn's a qualified social worker who began her career in health and social care as a domestic in a care home and then worked as a care assistant in a range of NHS and social care settings. She joined Stockton-on-Tees Borough Council as the Director of Adults Health and Wellbeing Services in 2023 and previously had been Assistant Director of Adult Social Care at Lincolnshire County Council and City of Doncaster Council. So brilliant to have you with us, Carolyn. And I mean, again, if you're able to give us your sort of sense of the sort of key levers that are available to help us move forward this critical agenda around an integrated health and care workforce. Thank you.
Thanks, Vic. Morning, everybody. I was just trying to get myself off mute. It's always a good start. I've done it twice this morning already. So, yeah, I think what was really interesting was hearing from colleagues from Leeds and also Brandon around what struck me the most was they're both putting people at the centre of the care. So actually, this is about how do we put people at the centre of their care and give them greater choice and control. Not unlike Jane, I've been around a long time and I've been doing this for 30 years. And and we seem to have talked about it an awful lot for a long time. But it does feel like we've got a bit of an opportunity, and that the time is right to actually put people at the heart of what we do. And I think if we do that, we can't go far wrong. And if we allow people greater choice and control, actually we'll come up with some really good innovation and some really good alternatives to the way we've delivered traditional care. I mean, ultimately, the Secretary of State has put forward his plan, and clearly integration is something that he is very keen that we push forward and keep building on. Integration is something that we've also talked about for a long time, and I think there's something for us as a sector to understand, what do we mean by integration. All of us talk about integration, but I think lots of us have very different ideas on what integration could look like and should look like. It's clear that we've got the challenges in the workforce, and both across health and care, and how do we work collectively to make sure that this is a career of choice for people. So you talked about in my bio, I started off as a domestic and a care assistant. I'm not special. There's no reason why thousands of our staff members couldn't start off as domestic and care assistants and become, if they really want to, and are a little bit twisted, become a director of adult social care. But we should have good, strong career pathways. And I think that's something that we need to start to build collectively in a more integrated way, so that people coming into the sector can see they can do whatever they want to do and be whoever they want to be. Obviously, with the ADAS national role, we continue to work really closely with colleagues, both in the department, but also across the NHS, around how do we ensure that we've got a strong workforce in the community. I think as a sector, we need to get much more vocal about being more than just getting people out of hospital. Actually, what we're all really good at is keeping people at home in the community, where actually most of the people that we work with want to be. So how do we ensure that we're empowering providers and individuals themselves to have good plans in place and good support in place to remain in the community? And then the big elephant in the room is funding. I know that Kate talked about it from a Leeds point of view. We didn't see any great promise of funding in the recent budget, which was a little bit disappointing. There was a mention of, I think it was 600 million, but we're still waiting on what does that mean? What does it look like? Is it new investment? And also with the employee rights bill, and where do we sit with equal pay and how that will impact? And not to underestimate the impact of the changes to the national living wage and also the national insurance. I think those are the elephants in the room and are key enablers, but also key challenges for providers, local authorities, commissioners across the board. So I think there's a lot of really positive work happening. I think we all say this, don't we, every year, we're in the most challenging times we've ever been in. It does feel like we're in the most challenging time of my career financially. But I think there is something about, what do they say, is it necessity is the mother of invention. So actually, I think we need to think differently and be really radical and not be afraid to do things really differently. And that's what we've heard about this morning. So back to you, Vicky.
Great.
Hopefully I haven't taken up too much time.
No, that's fine. Very interesting. Thank you very much, Carolyn. And then finally, last but definitely not least, I'm delighted to welcome Tom Surrey to the panel. So Tom is the Director for Adult Social Care, Workforce and Policy at the Department of Health and Social Care, and also the Civil Service Head of Place for the South West. Tom's worked in the DHSC since 2020 and in the civil service for over 20 years. Previous roles have included corporate and policy roles in the Ministry of Housing, Communities and Local Government, the Economic and Domestic Secretariat in the Cabinet Office and at DEFRA. And Tom's based down in the South West. So Tom, same questions for you in a sense of your reflections, levers and how we move forward with a stronger focus on an integrated health and care workforce.
Fantastic, Vic. Thank you. It's really great to be with you all this morning. I think the first thing I would say in way of reflection is actually a massive thank you to the colleagues who presented today and the organisations they represent for, not to put too fine a point on it, walking the walk. So, Brandon are one of 30 care providers across the country who are early adopters of the care workforce pathway, which we developed with the sector and published just coming up on a year ago now. And the learning that we're getting from, as I think they said in their presentation, from those early adopters is just absolutely fantastic. and is going to be so valuable going forward. So a massive thank you to them, and to colleagues in Leeds. Leeds has been really at the forefront of thinking about some of the new models that have been described, and also thinking about the workforce in quite a holistic way. I think the sort of my reflections on the way forward are that, you know, we have seen a new government come in, and some of us have been lucky enough to spend time with, you know, our Secretary of State and indeed with the Deputy Prime Minister, both of whom speak really passionately about the importance of the care sector, and particular the importance of the workforce in the care sector and their ambition to see it professionalised. I think there's real some credit to them actually around the workforce pathway, in that whilst it was developed under the previous administration, they are still very supportive of it, and indeed, you know, it's our intention to continue to develop that, taking the learning from the early adopters, expanding its scope, to Carolyn's point. So we have started with the real frontline care worker roles, but we are moving in the next phase up into some more specialist roles and more senior roles, and that starts to really map out that pathway that Carolyn was describing. So I think that is part one, and I really hear loud and clear the messages in there about moving, trying to move that pathway into a more digital space, and hopefully that will be something that we can support as we move into from an early adopter schemes into wider rollout, which is going to be the critical thing here. It's fantastic we have 30 providers using it, but as we all know, there are 18,500 providers, and really we want all of the providers to be using this. The second thing I will talk about a little bit specifically is that we have done in the department and continue in partnership with Skills for Care and others, is the development of delegation principles for the social care sector. They have been updated following really considerable consultation engagement, much of which led by our amazing chief nurse for social care, Deborah Sturdy. And a new version of those will be published on the Skills for Care website very soon, if they haven't been already. I'm afraid I've slightly lost track of the date of that, if I'm completely honest, but it's soon or recent. The third thing is to pick something else that I know is happening in Leeds, but also happening here in kind of my hometown of Bristol in the southwest, which is the establishment of local academies for health and social care. And I think that's going to be a really critical step forward. So the Leeds Academy is up and running. There is an academy based at the University of West of England here in Bristol, and that is really starting to look at how we can really integrate the workforce development through academies, qualifications, and existing educational institutions further and higher. That, I think, for me is going to be the a really important step in the long term, and really chimes with some of the things that we will have heard the Secretary of State, you will have all heard the Secretary of State talk about at conference and since, including this week, I think, about how the importance he places it on the concept of neighbourhood health services that really do embed the community and keeping people in the community, to Carolyn's point, at the heart of what we do. So, Vic, I hope that's helpful. Sorry to have gone on a little bit too long.
No, that's really helpful. Thank you, Tom. So could we have all the panelists back? And I don't know whether we need the slide anymore, Rachel. It might be give people a chance to see people a little bit more clearly. Brilliant. Lovely. Oh, they all are. How wonderful. Great. So thank you for that. And we've got some questions that are appearing in the chat, but I just wanted, before we move on to those, just to pick up a couple of themes that seem to be coming through strongly. So Jane, you had a strong focus on leadership, I think, in the context of that, and it feels a bit like the examples we've heard from, in terms of either people choosing to be part of the early adopters or indeed choosing to remodel and deliver in a different way, are fundamentally underpinned by leadership in that kind of context. So I suppose that's a theme that we might kind of come back to a little bit. Funding wise has come up a number of times in the questions. I can see that already, but both about training, about education, access to education, qualifications, supervisors, etc., as well as the very important points you were making, Carolyn, around, how do we move forward from some of the really immediate sort of financial challenges that organisations have got there. And then I think, sort of to your point, Tom, that's sort of broader network of provision that enables any of this, education, particularly in that context. And we've had some real challenges, and I saw there was some commentary about the new T levels the other day in terms of dropout around the health and sciences T level, and the absence of sort of that post-16 qualification right now, in terms of what does that mean for kind of integrated opportunities for learning going forward. So they seem, I mean, they're opportunities, but also they are things that we have to kind of tackle head on if we're going to move ourselves forward from the position that we're in now. So we've got a couple of sort of process questions that I'll just ask in order to put people at ease that we're either going to be able to find the information or that we'll do something about it. So one of those is about how do we know who the early adopters are, if there is a sort of public list of those, so that people might be able to connect up if there's people in their local area who are doing that. And also there's a question about the local academies, and interestingly, you might know this, Carolyn, I was part of a session the other day which was being run, I think, through West Midland ADAS, which is bringing together those local care academies, I believe. So there is a network of them. Are you aware of that, Carolyn, through the ADAS links?
I'm not specifically aware of the West Midlands. I know that certainly when I was in Doncaster, Yorkshire and Humber also, there's several care academies there, and certainly in the northeast. It's a bit of a movement, I think, that is growing. So
yes, I think West Midlands were facilitating a national
so that will then academies. Sort of get pulled together.
Yeah,
I think the key for me is that it doesn't become another siloed social care element of that's the care academy over there and becomes very specific to local government. I think we need to bring other people on board as well and actually make them really robust. And I think the other key for me is how do we connect into local education providers and really link that academy into employment hubs, education, training, so it doesn't become some of them, and I'm not saying specifically, but some of them are actually just more about recruitment processes, and I think they need to be a bit broader.
Yeah. Okay, so let's have a look at some of the kind of, Tom.
Yeah, sorry, I just say, if I could I just come in on that point a little bit? So I think I think it was Carolyn who talked about sort of necessity as the mother of invention, also the moment of opportunity. And look, there is a moment of opportunity. So if you haven't, I would really encourage everybody to have a look at the Skills England report on the social care sector, and also kind of really absorb, I think, what the government is saying about skills and economic growth, and the importance of devolution as well. So I think there is a space for there is, clearly and obviously an ongoing space for government and the department, and we will continue to do what we do best at a national level. There is also a massive role for Skills for Care with their great local and regional presence. But actually, local systems need to take those national frameworks and apply them in a sensible way. And I could just completely want to agree with Carolyn. The academies that I think I mentioned, so one in the west of England, one in the Leeds, and I'm sure there are others, are very specifically about bringing together educational institutions, the health sector, and the care sector in a single place. And that has to be the model, I think, going forward.
Great, thank you. Carolyn.
Yeah, really, really quickly. I think the other thing that is a real challenge and opportunity to us all is we make a huge contribution to GDP. think something like 64 billion off the top of my head. I might got it. Jane's nodding, so I've got that right. So that's good.
Yes, 68.1 billion, isn't it?
Absolutely. And I think if that was any other sector, we would have a much stronger voice. And I think what we need to do is use that collective voice and that power, because if it was, I don't know, an industrial industry or whatever it might be, they would be very much at the seat of the table and driving some of these decisions. I think the challenge with the social care sector is we are so many providers. We're not one organisation. We're not one thing that they can go to. So I do think we need to really use that and drive that forward, because anywhere else we would be making a much louder noise.
Well, and presumably if it's an integrated healthcare workforce, it's worth an awful lot more.
Even bigger, absolutely.
I
didn't even want to guess at that, Vic. I hadn't got a clue, but yeah, I'll stick with what I know.
I'll give you a moment or two to work out that sum. Jane.
68.1 billion. So very, very close. So I just quickly wanted to add on to what Tom and Carolyn were saying about the academies. I know that Partners in Health and Care have got some information on their website about the more sort of career academies that I think you were talking about earlier. So there is some information online about those. One of the recommendations in the workforce strategy was national infrastructure for, training and development for adult social care, and that's, as Tom rightly said, that absolutely should be a space for skills for care. So it's one we will be exploring moving forward.
Great. And I mean, just keep us on the education for a second. There is a sort of broader infrastructure kind of question around assessors, supervisors, CPD, the things that again aren't there in that kind of context. So I think I guess it's just important that when we're having those discussions about skills, we're also thinking about the broader infrastructure requirements that are in there. Okay, so there was a bit of a nod towards digital, and I know it's a big part of the workforce strategy. I was struck a little bit by what Josh and Debbie were saying about kind of the perhaps slimming down of the digital side of skills in relation to the current role descriptions in the care workforce pathway. But I just wondered if you'd all got a perspective on what role you think digital has in terms of enhancing an integrated workforce, and if there were particular areas that we're not maybe paying enough attention to right now that you see will be vital going forward. Anybody can start. I'm going to go to Jane actually, because Tom, go on and go for it.
Well, look, Jane and Carolyn will have much more expert views than I do on digital matters. I think what I would just say two things. So the first is that the continued adoption and rollout of digital care records is a massive enabler of integration, and also to sort of voluntarily touch on the money point briefly. Is clearly a huge deliverer of efficiency in the workspace. So saving minutes, if not hours, each day. Ensure and to Carolyn's point about putting the person at the centre of the care provision, actually making sure that care providers do understand and have access to GP records, etc. Understand what medication the people they're looking for are on, what long-term health conditions that they are also facing alongside those that may have required them to access social care provision. So, in terms of digitization as an enabler of things, I think that's really important, and those care records are at the heart of all of that. I think, and I don't want to speak for colleagues from Brandon, I think what they were suggesting is that the digital skills required by frontline care workers might be slightly overstated in our work pathway from their experience. I can see colleagues on the call can't, but I can see I can see Deborah nodding away when I say that, and I think that's and look, I think that's that's exactly the purpose of doing our early adopters. What really works. I'm sure there is a huge digital skills gap, as there is across the whole country. and given perhaps some of what we know about the age demographic of the social care workforce, that may be higher than in some other sectors. But we need to get that right, and we need to make it a really practical tool for colleagues to use on the ground. So take that on board.
Thanks, Tom. Carolyn.
I love Tom's confidence in me around digital. If anyone who knows me will just go, no, not at all. I think there is something for us in the social care sector, slightly less so with our NHS colleagues, I think, around not being afraid of digital. I think we always feel like digital will get in the way of, because our job is relationships and people. I think we very often are quite nervous about how it could potentially get in the way. And I think also my experience, and I can only speak for me as a social worker, I'm not digitally savvy at all. And when you look at the age profile of our social care workforce, we're not as young as some other sectors, I would say. And I'm speaking purely for myself. So I think there's something for how do we start to really work with some of those innovators and some of those providers around creation of good digital tech that for me helps the business, which is what Tom was saying, the process side. There's a lot of process now in care, that paperwork element and all of those other bits and pieces. There's some really good stuff out there. How do we free up people's time? How do we free up carers' time to have more relationship interaction as opposed to maybe doing health checks and tests? And if we can get the digital to do that bit to free up more of the relational stuff, I think that would be a really big positive. But I'm an old-fashioned social worker who's been doing it for a long time. So there's probably Jane's younger than me, so I'm sure she'll come up with something far more whizzy.
I think I'm about 2 years younger than you, Carolyn, but have worked in the digitising social care team, so this should be something I can talk about. So following on from Tom's point, I think we're at close to 75% of care providers having a digital social care record, which is amazing. I mean that's a massive shift over the last few years, which is great, and that's down to government support and funding, as well as the team and a concerted effort across the sector, which is great. I think digital skills have improved significantly over the last few years, and we've got lots of free offers available for people to improve their digital skills, whether that be basic or more detailed. One of the things that the oversight executive for the workforce strategy have said is that we want to use the workforce strategy to move us from a sector that is quite kind of done to in terms of digital, and much more sort of proactive and able to like smartly commission digital technology and work better with technology suppliers and sort of really tell them what it is that we want and get that back in return, rather than sort of having it sold to us. So that's a real ambition of the workforce strategy oversight executive. And then I think just the last thing to say is that one of the recommendations in the strategy was that we pilot some care technologist roles, which would be a really great bridging role across health and social care. So a really great integration role, and very excited to say that National Care Forum are just about to start those pilots, or maybe have already started them. Thumbs up from Vic. So really exciting work going to happen there.
Great, thank you, Jane, and thanks for that. No, it hasn't started yet. It's just beginning that programme, but there will be work going on around that care technologist role. Somebody has just popped in the chat a question about AI, generative AI, and the sector. So I'm hoping that maybe somebody will be able to post in the chat. There has been some work done on it in answer to the question. There was the collaborative came together, cross-sector collaborative, in February this year to produce a sort of statement around the use of generative AI in the social care sector. Anybody is welcome to join that collaborative. So, and if we can pop in the chat, and tools and resources are being developed as part of that around the use of AI in the sector. And there were, very importantly, in the context of this conversation, and I'd be keen to hear from colleagues if they know if it's happened in the health context, is that there has been a specific session with workforce around their perspectives and views on the use of generative AI, and that brings up lots of questions. There's lots of ethical questions about AI, full stop, and lots of opportunities, but also understanding the perspective of how workers feel they might either be judged in a regulatory context or afforded any blame in relation to, you know, so there are really key points about how, as we move forward into more automated approaches or AI generated approaches to things like workforce delivery, care planning, assessments, etc., that we have to have all those considerations in there. So yes, and Rebecca's put something in about using AI around wound care. So I think there are lots of discussions around that, both generative and now understanding what agent AI might enable us to do as well. I wanted to bring us back to what you referred to as the elephant in the room, Carolyn, and there's been a number of questions that have been popped in the chat around funding, and Kate brought it up in her presentation as well. So one of the questions is about, you know, in the context of an integrated workforce, if we don't have parity of both pay and terms and conditions, how is that a possibility? And I think, you know, some of the work Kate has been doing has been looking to try and address you know, greater recognition of the skills and experience. Somebody else has put in the chat that the delegated healthcare tasks framework has now been updated and, as Tom mentioned, and is now published. So, you know, that always raises for me this really critical question of how do we shift in that integrated discussion care workers to a position where they're paid for the professional skills and expertise they deliver. And actually we've created a framework where we explain what that looks like, but what we haven't done yet is create a funding mechanism that enables that to be a possibility. So I think just your reflections on perhaps what, not necessarily, you know, I don't know that anybody's going to say that's the wrong thing to do, so I'm not going to ask you to say whether it's the right or wrong thing to do in a sense, but what do you think the levers are, or the things that need to change in order for that to be a possibility?
I mean, on a personal level, it's absolutely the right thing to do, and I don't think there's anybody who works in health and care who would say it's the wrong thing to do.
Yeah, quite.
I think that the absolute challenge is that local government and the NHS are in a position where that money is not available the way we currently do things. I was confident that the Employee Rights Bill would take us a step in the right direction, and I think it has. I think the current government certainly seem very committed to that equity of pay. But all of us in the virtual room have probably heard that for many, many years, and ultimately social care remains a difficult funding situation to fix, or would appear to be that it's a difficult funding situation. I think it goes back to that GDP. We are a strong sector. We must be one of the biggest employing sectors in the country, if not the biggest. So how do we really start to use that as a lever, as a collective voice? I think for a long, long time, and this is my personal view, and not that of ADAS or Stockton Borough Council, so I'll just put that out there. I think we're very easily divided and conquered. And what we need to do is stand together and find some common areas of interest and change, because a lot of us have been put in a commissioner-provider relationship, which makes things difficult. A lot of providers are in a competitive relationship. I think we're going to kind of have to put some of that aside and have a really strong collective voice about the time is now. We can't continue to support our most vulnerable in society with the current system we've got, because it's not working. We're not getting enough people coming through, and it's not all about the hourly rate, but actually there should be parity of esteem, and we should be on a level footing. So I think we need to be much stronger together. I think we need to stop being so easily divided and conquered as we have been historically.
Thanks. Tom, I didn't know if you wanted to, I know that there's been much stronger focus from government around the economic contribution of social care.
Yeah, so I'm afraid, look, look, my answer is going to be much less interesting than Carolyn's and much more and much more official. But look, but I would go a little bit further in talking about the importance of the Employee Rights Bill and the commitment to establish the first ever fair pay agreement for the social care sector. That legislation that is in the House is a framework, and I think we are all realistic that this is not an overnight solution. It will take time. It will take time to get it right, and that's the most important thing, is that it has to be right. But this is a significant change for the social care workforce, and we're really keen that we've established our senior working group. We were really lucky to have 4 ministers attend that, which shows you how seriously government is taking it. So that is really important. I take slight issue, Vic, with there is no funding mechanism. There is a really clear funding mechanism. It's called Section 75 of whichever bit of health legislation it is. It exists entirely to allow local systems to co-fund interventions between NHS and social care. It's just about what the incentives are to use the mechanism that is the question, I think. And I suspect that over time the combination of a fair pay agreement, a commitment to integration, neighbourhood health will start to see that happen. I think we are seeing some novel approaches in that space, but it's early days.
Well, yes. More work to be done in that sense. I mean, and I guess a question about the framework, whether that is specifically cited in that. Or could that link be made more strongly?
I can't remember the last time I read Section 75 of whichever act it is, so I don't know exactly what it says. But it's a widely used mechanism.
Yeah. For the funding, but I don't think I don't think people's experience on the ground is it's widely used in the context of transference of funding to enable enhanced roles. But let's not come up with examples when we haven't got the people here to comment on that in that sense. I didn't. So Carolyn.
We do have Section 75. It is used, but I still think we're not strong as a sector on integrated commissioning. I still think that between our NHS colleagues and local government, we are still commissioning a lot of provisions separately. And I think there is something about how do we perhaps use whether Section 75 is the right mechanism or not. We can debate till the cows come home, because then you get wrapped up in all sorts of legalities and all sorts of other things. But I do think there's something about how do we start to work more strongly together around commissioning and joint commissioning, which makes it easier for providers. Probably the feedback I've had from providers over the years is dealing with so many commissioners is a challenge, and actually we've all got a shared vision and a shared goal, so how do we start to use it? But the Section 75 is there, but I agree with Vic, I'm not sure we use it to its best effect. I think it tends to be something that's used between the NHS and local government rather than going anywhere else. But yeah.
And I think we have a wonderful opportunity, I would just say, in the context of the future of electronic health records, is that actually it can become much more straightforward to signify and identify health-based tasks and then pay the person who delivers them. So I think actually, if we go to the context of a properly integrated workforce, a shared record which identifies whether it was the social care workforce who delivered the wound management, or if it was the healthcare, and then the payment flowed with that, I think that would address a lot of kind of shifts around that. Anyway, we are coming to a close of this session, so huge thanks to our speakers. I will give you one last opportunity for a final reflection on the discussion we've had to date, and hopefully a final chance to bring Rebecca back in and join us as we summarise the session. So Jane, let's start with you again as you led us off.
Thanks, Vic. Yeah, I think the message I want to leave us on might be a bit cheesy, but I want us to have a bit of hope. And I think there are, hopeful shoots in the sector, and very much led by the sector. And I think working with government, working with Tom and his team, I think there are opportunities for us to do as Carolyn was saying, and use our collective power more. The workforce strategy is a really great example, but the relationships that we've formed and the opportunities that are there, I just think there's so much we could achieve, the size of our sector and our economic contribution. So let's try and hang on to that hope and make it real.
Brilliant. Carolyn.
I'll follow on with Jane's cheesy message, and I will say it's still the greatest job in the world after 30 odd years. Not every day, but most days it's still the greatest job in the world. I think the message that I want to leave is devolution, place, more coordination of budgets and integration of budgets. I think if we can get that strong, then we're in a much better position. And let's really start working together to shout about how brilliant we are and how much contribution we make to the national economy, but also, most importantly, the contribution we make to people's lives, which is more than let's get them out of hospital.
Great. Tom.
No, no, I'm going to be really negative. No, I'm not. I'm going to be really, really. No, those are great messages to end on. I think mine is. I'll end where I started, which is a massive thank you to colleagues in Leeds, to Brandon Trust, our other early adopters. But they are illustrative of what I see every time I visit a local system, every time I speak to people connected to the sector, which is there is huge innovation happening in the care sector. There's real ambition to take forward the integrated workforce agenda. And as Carolyn has already said, that is there to be taken. All of us on the call in terms of local leadership, skills for care, or government will have a role in that. But we all need to be just really positive about the opportunity, just slightly making sure we're not letting 1,000 flowers bloom, which is the history of innovation in my experience of the care sector. Loads of great things, they never quite get to scale. So the challenge for us collectively, I think, is how we take the best of what we're learning and make sure it's happening tailored for place, as Carolyn says, but consistently.
Brilliant. Thank you very much. A real privilege to have a chance to chair that discussion, and absolutely grounds for optimism, some grounds for kind of urgency, I suspect, as well, in the context of what we all know is happening with the demography of the country and the need to sort of ensure that the right care is available for people when they need it all across the country. But integration clearly presenting some real opportunities there, and I share Tom's thanks to Kate and Debbie and Josh. So Rebecca, I'm going to hand over to you. You've had a chance to sort of sit back and listen to some of that, and I wonder if you've got any final comments as we draw the session to a close.
To hear all of that conversation. I think that there is lots to be optimistic about. I think the focus on neighbourhood and place is really important. Integrated care systems are very focused on the one workforce and how to connect social care, the third sector and health. It's not without its challenges, though, because of the multiple providers and how do we do that? And therefore, I think, how do we share some of what is happening and being done well? And so the forum today has been great for enabling that. But it is hard, I think, sometimes to get out the messages. I think Skills for England will be an opportunity as well for both health and care to come together and show how collectively we can help with addressing things like social mobility, providing people with good jobs, as well as enabling our future workforce to come together to serve the communities that we're here to do. So lots to be optimistic about, and for health to be a very strong ally in this space, and to also ensure that we continually make sure that people recognise the full breadth of social care, and it's not just about discharge.
Fantastic. Thank you. So I think that draws our session to a close. Thanks again to all the speakers and to the amazing panel that we've had here. As people have mentioned, the slides will be shared, and there will also be a write-up of the session. So please do look out for those as they become available. And there's lots going on in this space. Tom and others have mentioned there's legislation that's out there, consultations and discussions, work going on around fair pay agreement, the great work that Skills for Care facilitated around the workforce strategy. ADAS is doing lots of work in the space around workforce as well. And, you know, we're getting lots of great support and engagement from colleagues at NHS employers as well. So lots to be hopeful about, and many thanks for your time in coming and listening in and joining in with all the questions, and anything that we haven't been able to answer, we will give it our best shot and come back to people where people have asked about sort of technical things of links and connections. We'll also try and include those in the write-up. So enjoy the rest of your day, and many thanks again.
Thank you all. Bye.